guests, ladies and gentlemen, good afternoon, and welcome to the webinar on how hospitals reacted for the prevention and control of COVID-19. Please allow me to introduce our honorable guests for today's event. President and CEO of Taiwan External Trade Development Council, TAITRA, Mr. Walter Ye.
Hi.
Vice President of City Children's Hospital, Dr. Dean.
Yeah.
Hello, Dr. Dean.
Yeah. Good afternoon, ladies and gentlemen.
And our medical team from Taipei Veterans General Hospital. Director of the Department of Chest Medicine, Dr. Chen Yuming. Chief of the Pediatric Infectious Diseases Division, Dr. Hong Miao-Qiu. Chief of the Respiratory Therapy Division, Dr. Yang Guangyao. Dr. Xiao Yihan, Division of General Chest Medicine. And our medical team from City Children's Hospital. Head of Infectious Disease Department, Dr. Nan.
Yeah. Yes, I'm listening. Good afternoon.
MD of ID Department, Dr. Jin.
Good afternoon.
And Dr. Lau.
Hi, everyone.
Camera.
Taiwan Smart Healthcare Companies. Project Manager of Taiwan Physiological Sensor Company Limited, Ms. Yuxia Xu.
Hi, everyone.
Director of Marketing and Sales Department, Medical Tech Company Limited, Mr. Nick Liu.
Hello, everyone. Good afternoon.
Thank you very much for your time and participation today. Now let's welcome President Ye to deliver opening remarks.
Honorable speakers from City Children's Hospital, Ho Chi Minh City, Taipei Veteran General Hospital, ladies and gentlemen, good afternoon. On behalf of TAITRA, the Taiwan External Trade Development Council, it is my pleasure to join you in this joint webinar to look at both Vietnam's and Taiwan's efforts in combating COVID-19. Because of Taiwan's deadly experience of SARS in the year 2003, the Taiwan government reacted extremely quickly to the current coronavirus pandemic by immediately initiating border controls, putting together a national face mask production team, and implementing technology-based epidemic prevention methods. TAITRA also helped to assemble a COVID-19 task force consisting of hospitals, medical equipment, and medical supply, and smart healthcare companies. Furthermore, a week ago, TAITRA launched an online Taiwan anti-COVID-19 pavilion, which shares Taiwan's experiences and matches supply and demand needs for medical technology and medical devices. The pavilion also enables international visitors to seek the best solutions for themselves. TAITRA has been established for 50 years and has 64 overseas offices around the world. We are committed to actively meeting the demands of international visitors and dealing with the challenges of this pandemic together with the world. Before I finish, I would like to thank you all for your participation today. I sincerely hope this event will be of benefit to everyone here. Thank you.
Thank you, President Ye. Next, please welcome Vice President Dean to deliver an opening statement. We welcome Vice President Dean to deliver an opening statement.
Yeah. Ladies and gentlemen, I'm Dr. Dean, is the Vice Director of the Chile Children's Hospital. Today, I would like to introduce my hospital and our staff and our activity. Our hospital is operated in 3 years ago, and we just inaugurated 2 years on the June 1st of the 2018. Our hospital located in the Ho Chi Minh City in South Vietnam. With the Ho Chi Minh City, the population about 10 million people. Is the vibrating and economy center, financial center of the Vietnam. We have 3 hospitals, children hospital, children hospital 1, children hospital 2, and our hospital is the new building, organized and government sponsor run state hospital. Here is our hospital view from sky. We had 2 buildings. Is the first building you see directly is the emergency and outpatient clinic department, and another is at the left side is the inpatient area, and we also have the secret area for infectious disease. Is the department of the Dr. Na. Is we also call the kingdom of the Dr. Na. We have the 2 now. The government invested $200 million for building the hospital, and our vision to become a modern pediatric medical center with on subspecialty to provide the best care available to children in Vietnam and in the region, especially in the South Vietnam. We have 1,028 bed capacity, and we have 1,073 staff, including 2,045 doctors and 487 nurses. We have with the activity. With the core value is the being committed, being self-motivated and collaboratory and executive. We had a total 39 specialty, including the surgery, general pediatric and intensive care, neonatology intensive care, intensive care, surgical intensive care unit, and we also have the laboratory department, including the imaging diagnostic, including the MRI, CT scan, and we also have the nuclear medicine. Here the infectious disease is the cigarette area where we let the patient with COVID-19 here, and we have the isolated negative register room. We have the sick room like that, and we care on the patient from mild symptom to the severe condition with the ventilation, mechanical ventilation, respiratory support, and self-resuscitation with the ECMO. We have available for severe patients. Every year in the outpatient clinic, we receive 1,500 to 2,000 patients in outpatient clinic, and we also have 800 to 1,000 patients in inpatient area. Most of the patients in the respiratory disease, and also we have the infectious disease such as the dengue fever, hand, foot, mouth disease, or other infectious disease such as the varicella, measles, and meningitis, etc. And in the laboratory, we have the high technique of the imaging diagnostic, such as the MRI, CT scan, and we also have the modern operating room. Like that is we have the hybrid surgery operation room, and we also have the resuscitation intensive care with the CRT and ECMO, and we also the neurosurgery department with the machine for locating the injury by the computer to guide the surgeon to perform the operation on the patient with the neurology. Here is some patient we run with the cord blood in severe condition admitted our hospital. The patient had the multi-trauma and multi-dysfunction organ dysfunction syndrome. We activate the cord blood, and we have the multi-disciplinary team to resuscitation the patient. And we also run the ECMO with the newborn. Here the baby with the meconium aspiration syndrome with the severe respiratory failure. So we run the ECMO, and the patient gets better. We also have the collaboration with the other team, other organization and hospital. We signed 10 MOU with the international organization like that in the King Hamas University, Children Line, and even your university, your hospital. We have also the slogan every year, such as the Dare to Win, to create and innovate for develop. So we try our best to develop our hospital with our youngest usual staff, and we did training, and here is the opportunity to cooperate with you, and we also would like have receive experience from you about the COVID-19 prevention and control. So that's all. We hope our conference will successful. Thank you so much.
Thank you for your introduction, Dr. Ding. Now we would like to have a quick photo shoot. Please face the camera at the front for the pictures. Thank you very much. Now let's proceed to today's first section, some experience sharing by Taipei Veterans General Hospital staff. Please welcome Dr. Hong to deliver her speech on her experience with COVID-19 in Taiwanese children.
Good afternoon, everyone. My name is Miao Chu Hang, and I'm the chief of the pediatric infectious diseases. First of all, I congratulate on your government to focus on the children's health, so you can get a very good facility to look after the kids. And now I will start my talk talking about the COVID-19 infection in children. We share some experience from Taiwan. Okay, up to yesterday, all over the world, 7.6 million people have been diagnosed as a COVID-19 infection. And out of all the patients, unfortunately, 427 patients died of this infection. What about Taiwan? Currently in Taiwan, we have tested 74,000 patients, and there are a total of 443 confirmed cases. And the first one was confirmed on the 21st of January, and she was a businesswoman coming back from China. She had the symptoms, so she reported herself to the healthcare system, and she got diagnosis quite quickly. And we then experienced some imported cases and human-to-human transmission on our land. And the latest human-to-human transmission occurred on the 12th of April. That is to say, we haven't had any human-to-human transmission in Taiwan for longer than 60 days by now. And the death toll is 7. And so far, there are still 12 patients in isolation. And let's look at the age distribution of all the cases with confirmed COVID-19. I eliminated 5 cases as I was not sure how old they were. I downloaded all the data from our CDC. And as you can see on the figure, most of the patients are between 20 to 29 years old. And the reason for that is they are a lot of them are students studying abroad or working abroad. And once after the COVID-19 outbreak occurred all over the world, they tried to come back, and some of them got infection. And some patients have age older than 60 years old. I think because they are retired and they got time to travel all over the world. And some of them are still doing business all over the world. That's why they got the infection. We focus on children's case now, and as you can see, there are only 4 cases aged less than 10 years old, and there are about 20 patients aged between 10 to 19 years old. And let's take a closer look at the 24 cases that we got with age less than 20 years old. I'm not sure whether you can see clearly. The image is a bit small. Okay, but The first confirmed case in the first confirmed pediatric case in Taiwan is an 11-year-old boy. He was confirmed to have COVID-19 on the 25th of February, and he actually got the infection from his family. And the latest one was confirmed to have a COVID-19 on the 6th of April, and he was only 4 years old, and he also got the infection from his family. And if we have a look at all the age distribution, only 4 patients are aged less than 10 years old, and gender-wise, I think they are quite equal. And symptoms-wise, there is only 1 patient without symptom, and he got screened because he had contact history. And about 17 patients had fever, so they will be about 70%. And there are 9 patients presented with cough, and 6 patients with a headache. And if we look at how they got the infection, you can see only 5 patients got the infection in Taiwan. And the first case, as I mentioned early on, he got the infection from his family. And the second and the third patient who got infection from Taiwan, they actually got the infection from their classmate who traveled back from Greece. That will be the case number 2. And the other 2 cases, they all got infection from their family. And as we've only got the age group between 10 to 19, so I think quite a few of them has reached beyond 18 years old, and they got the infection from abroad when they came back to this country. And so the most common country they went to would be the USA or UK. So you might wonder how we diagnose all these patients, or how we define all the cases, or how we ask the clinicians to sample for diagnosis. We have the most updated version of the recommendation from CDC Taiwan on the 12th of April. And before we mention the criteria, you might want to have a look how we separate those infectious patients from other non-infectious patients. We learned the experience from SARS in 2003. So we set up the fever screening clinic rather quickly. And if the patient presents with fever, he or she will be diverted to the clinic. And in the clinic, they will be asked about their contact history, travel history, or cluster history. And all the doctors and nurses in the station, they will wear the full PPE. So it's rather safe to see all these patients. And the criteria to notify the CDC would include a clinical criteria and epidemiological criteria. Of course, there's also laboratory criteria. And let's have a look. If you have got fever or symptoms of acute respiratory tract infection, plus a recent travel or living abroad or contact history, then you are your doctor will notify you to the CDC and take samples from the take the sample from the patient. Okay, and if the patient has got abnormal sense of smell or abnormal sense of taste or diarrhea of unknown etiology, plus any traveling history or contact history, this patient should be notified as well. And the third one would be if the patient has got community-acquired pneumonia, and the clinician highly suspect the patient has got COVID-19, and this patient will be notified to the CDC. And as long as the patient is notified, and he or she will be sampled, and the sample will be tested for COVID-19. And while we are waiting for the test result to come back, the patient will be admitted and given treatment. And all the patients with positive COVID-19 testing were admitted and isolated. The criteria for discharge is 3 negative testing. And here comes another question. What if after 3 negative tests, the patient has another positive test? What do we do? Okay, let's analyze all the cases with this situation. As of 22nd of May 2020, a total of 4 patients completed isolation after 3 negative testing for COVID-19. But another positive test was noted. So our current policy is that as the positive testing could be related to that virus without risk of transmission or infection, there's no need for further isolation. Okay, and there are a few review articles on children's COVID-19. I think because of the time, I think it's running out, so I will leave it talk to the next speaker. Okay, thank you for your attention.
Thank you very much, Dr. Hong. Now let's welcome Dr. Xiao to deliver his speech on lung ultrasound changes in critically ill patients with COVID-19.
Thank you for the introduction. Good afternoon. First, I would like to thank the TITRA to invite me to join this webinar with our friends from Vietnam. And maybe I should start with a big congratulations to our friends in Vietnam for your extraordinary achievement on combating COVID-19. You have only less than 400 cases and 0 deaths. That is very incredible. So I'm looking forward to learning from you in the following speech from you. So today I'm going to share our experience of a patient recovering from COVID-19 ARDS, and tell more about the application of lung ultrasound in that. Okay, next slide. Okay. So this is a 75-year-old obese lady, and she had a hypertension and diabetes under medication control, and she had a surgical history for his clavicle fracture and breast cancer a few years ago. She traveled from to America and Europe in this February and come back to Taiwan in mid-March. 5 days later, after coming back to Taiwan, she had a low-grade fever and a cough, and therefore she was admitted to a local hospital with a PCR confirmed positive for SARS-CoV-2. So this is the chest X-ray on day 1. You can see there's no significant pneumonia on the chest X-ray. However, 10 days later, she developed a progressive short of breath and some respiratory distress. You can see there are some consolidations on bilateral low lung field. And 1 day later, next slide please. Okay. 1 day later, there is a severe hypoxia, and the patient was then received endotracheal tube intubation and mechanical ventilation because of the respiratory failure. And in that critical condition, she was referred to our hospital for further intensive care. Next slide, please. Okay, so upon arrival in our hospital, she had a very high fever and a low BP. She had a shock status, in need of norepinephrine pump, and you can see the PF ratio is less than 100 mmHg, which indicating she had a septic shock with ARDS. So for that ARDS, we gave the patient with crystalloid resuscitation for the shock and lung protective ventilatory strategy for her ventilation, for her ARDS, and also deep sedation and neuromuscular blocking agent. And the prone positioning was not performed because of her shock status, and the laboratory data on arrival showing severe lymphopenia, elevated D-dimer, and LDH ferritin, and luckily she had a preserved renal and liver function. But the CRP, procalcitonin, and lactate are pretty high, indicating a severe abscess. severe sepsis. Next slide. So despite of this intensive care, the hypoxemia persisted, and therefore we apply a VV ECMO for this patient. Next slide. Okay. So this is a quite busy slide, but I would like to invite you to focus on the bottom box and showing that there we gave the patient with an empirical antibiotics according to our IDE specialist recommendation. And there's our vital sign on the upper panel of this slide, and you can see the high fever subsided after VV ECMO and empirical antibiotics. And the yellow bars refer to the cyclothreshold value, see the CT value of the virus PCR sampling from different sites, including nasopharynx and saliva and endotracheal aspirate. And the lower CT value means the higher viral load, and CT value more than 40 was considered as a negative PCR result. So you can see at admission the CT value was quite low, meaning the very high virus load in his respiratory tract. And we also gave her the hydroxychloroquine according to the evidence showing that it would have the potential to inhibit virus endocytosis. However, despite of this intensive treatment, the PF ratio did not really improve a lot, and therefore, and the chest X-ray also showed no significant improvement. There are still lower lung consolidation, and therefore we perform a recruitment maneuver with the target airway pressure of 40 to 45 cm H2O on day 18 to day 20. And that is for her ARDS. And despite of that, you can see next slide. Okay, so the PF ratio did improve, but only a little improve with the PF ratio still less than 300. And notably, the chest X-ray after the recruitment maneuver actually did not show any improvement. There are still basal lung consolidation on the chest X-ray. So that is really frustrating. Next slide. However, we found an interesting finding on lung ultrasound. As you can see, this is the chest X-ray and lung ultrasound finding of her lower lung field, and showing there is extensive consolidation on lung ultrasound and the chest X-ray. Next slide. And right immediately after the recruitment maneuver, you can see the chest X-ray did not show lots of improvement. However, next slide. Okay. However, on the lung ultrasound, you can see return of the B line, meaning the reopening of the lung. So that is really encourages us to believe that the patient's lung is still recruitable instead of stillness by the ARDS. So that gave us hope. So next slide. So and therefore, and at the same time, you can see the CRP, procalcitonin, and lactate decrease gradually and almost return to normal. And therefore, we gave the patient the tocilizumab monoclonal antibody against interleukin-6 receptor. And after 2 doses of tocilizumab, you can see the chest X-ray improve dramatically. And about 1 week later, the PF ratio improved to almost 300. So that is really inspiring. However, after 1 week later, the patient developed, next slide please, developed a fever and septic shock. So this is the chest X-ray on day 26. And next slide please. Okay, this is, sorry. Okay, this is day 30. You can see another episode of sepsis and pneumonia occurred with the sputum culture yield Stenotrophomonas mitophilia. And therefore, we treat her septic shock and consult our ID specialist to do antibiotic adjustment. Next slide. Okay, so luckily, after this management, the patient smoothly recovered from the septic shock. And in this week, next slide. Okay, in this week, there is some bleeding tendency happened to her, including lower GI bleeding. So it is probably due to prolonged use of VV ECMO. And therefore, we try to turn down the gas flow of the oxygenator, and the patient tolerated well. So the patient was successfully decannulated ECMO on day 36. And then we try to start a weaning protocol for extubation for her. And after training, a few days training, the patient successfully, oops, last slide please, last, okay. So the patient successfully weaned from mechanical ventilation on day 44. And at the same time, we have noticed that the CT value of the patient showed negative in three set in row on day 41, day 43, and day 45. And after confirming to our CDC, the patient was free from the isolation, and the patient tolerates a very low demand of oxygenation on day 50, and the patient was discharged smoothly after 2 weeks of rehabilitation on day 75. Okay, so this is the serial change of the lung ultrasound finding of this patient. You can see initially when the patient was on ECMO, you can see extensive consolidation in bilateral lower lung field, and convalescent B lines on the lower lung field after the recruitment maneuver. And when the condition got improved, you can see the B line gradually turned to discrete, and the extent of the consolidation also decreased. And this is the day 45 after the patient weaning from mechanical ventilation. You can see only a small pleural consolidation on right lower lung field, and there's a minimal B lines on middle lung. Okay, next slide. So we also perform a chest CT for this patient, and you can see there's a residual ground glass opacity, and there's a traction bronchiectasis in her middle lung field. Surprisingly, we don't notice severe honeycombing or fibrosis on the CT. That is quite different from the SARS in 2003. Next slide. Okay. So as Chief Hong said previously, the COVID-19 pandemic had already infected almost 8 million people worldwide and caused almost 500,000 of deaths, and the case mortality rate is almost 6%. And in Taiwan, we are lucky to have only 443 patients and 7 deaths. You can see the most of our case, almost 80% of our cases are imported, happened mainly in the March. And the other epidemiology data, you can see the gender was equally contributed, and mostly are in their young age. There are only 14 of them are elderly patient with the age more than 60 years old. And most 70% of them are mild disease, but there are 8.4% of them develop a severe pneumonia or ARDS, requiring mechanical ventilation with 24 patients and 7 patients in need of ECMO support. And the total case mortality rate is 1.6%, which is quite low compared with the whole world. However, you can notice that in the critical ill patient, for those who needed of mechanical ventilation or ECMO, the case fatality rate is very, very high, almost 30% to 40%. That data is quite the same from the study published worldwide. But we have to notice that the earlier publication from China in this January, you can see there are almost 80% of that in the critically ill patient. I think that is the result of the system, their medical system overload and the hospital flooding of COVID-19 patients. So I think it is important to have a good policy to like Vietnam and Taiwan to close the border quickly and give universal mask. That is the point which was recommended by WHO recently. But meanwhile, I think the other point is to set a guideline from the expert to teach the physician and medical team how to manage this kind of patient. For example, we have guidelines from Surviving Sepsis campaign. We also, in Taiwan, the Taiwan Society of Pulmonary Critical Care Medicine also had a clinical management guideline of COVID-19 with acute respiratory failure. Which was written by many of Taiwanese experts, including our Professor Yang as a deputy editor. That tells the physician how to follow the guideline with to minimize the damage. And talking about treatment, we have many potential candidates, including convalescent plasma to inhibit the virus fusion, or hydroxychloroquine to inhibit endocytosis, or some antiviral drug such as remdesivir to inhibit RNA polymerase as a RNA polymerase inhibitor. However, as we know, next slide please. Okay, oops, sorry. Okay. However, as we know, there is not a single drug has been approved by the FDA. That means that we don't have efficient evidence to say this drug is very efficient to treat COVID-19. So I think the best supportive care might be the most helpful for the patient to get through these obstacles. So talking about the best supportive care, we need to monitor the disease progression. So I think there's no doubt to say that the chest CT is the gold standard to monitor this disease, including the ARDS. So this study reported from China showing that most of the COVID-19 patients have a bilateral low lung peripheral distributed ground glass opacity and consolidation. And in most severe cases, there are multifocal and diffuse distribution. So it is good to perform chest CT. However, in our patient who was critically ill, it is very difficult to do the chest CT for this patient because it will be very dangerous to transfer out to ICU according to his very high O2 demand and hemodynamic instability. Besides, transfer out to ICU may cause the spreading of the SARS-CoV-2. So I think that is the important role of lung ultrasound as the surrogate to monitor disease status. So in this slide, you can see the lung ultrasound of COVID-19 could begin from normal lung aeration to discrete B-line to convalescent B-line and small pleural consolidation and extensive consolidation. And our patient initially showed extensive consolidation on right lower lung field, and gradually when the symptom got improved, the extent of consolidation decreased. And on day 47 after extubation, there are only residual pleural consolidation, and on day 59 you can see the normal aeration lung on lung ultrasound. So just showing the other way around. So the other supported way to help our patient with ARDS, which was commonly used, is recruitment maneuver. That is applying a transient high airway pressure to open the collapsed lung and improve the gas exchange, which was also recommended in our Surviving CSF campaign. But I think the most important thing is to evaluate the effect of the recruitment maneuver. So this is the article published from China. They use a mechanic-based index called RA ratio to evaluate the recruitability of the lung with a very complex formula. You can see the lower panel. You can see if the patient were put into a prone position, the RA ratio increase, meaning the recruitability of the lung. But this, as I say, the formula is quite complex, and I think it is not able to reveal which part of lung has been recruited. Next slide. So therefore, last month there's a study published in Intensive Care Medicine. They categorize they identified the lung ultrasound finding of COVID-19 into 4 different categories, including low probability, intermediate probability, and high probability of COVID-19, and also a diagnosis other than COVID-19. So the authors think this is a very useful tool and category to do the triage in emergency department. But in the other hand, I think it is very useful to monitor treatment response in our ICU, such as in our patient. As you can see, before the recruitment maneuver, you can see the extensive consolidation, and immediately right after the recruitment maneuver, you can see the beeline appearance and meaning reopening of the lung. Okay, so here's my conclusions. I think our way of life had greatly impacted by the COVID-19 pandemic, which caused millions of infected and hundreds of thousands of deaths. And there's a very great challenge especially in the critical ill patient with COVID-19. And the fatality rate is very, very high, especially when the medical system cannot support the amount of the patient. And there are some, despite of there some candidates to treat COVID-19, but it is still lack of evidence to prove that the efficacy, their efficacy from the randomized control trial. So as I mentioned, but the best appropriate care may be still very helpful for this patient to get through this obstacle. So in today's presentation, I hope to persuade you to use the lung ultrasound to provide a real-time information for our physician in a non-invasive way. And that is also avoid patient transfer out to ICU and also avoid SARS-CoV-2 spreading. Next slide. So last but not the least, I would like to thank the leadership of our hospital and the development to support us to establish a well-prepared medical team to save the patient's life, including our superintendent, Professor Zhang Deming, and the head of our department, Professor Chen Yuming, and also Professor Yang Guangyao as the leader of our critical care team to save this patient's life. So with that, I thank you for your attention. I'm ready to take questions.
Thank you very much, Dr. Xiao. And next, we will move on to today's second session, experience sharing by staff from the City Children's Hospital. Please welcome Dr. Jing to deliver her speech on COVID-19 prevention and screening procedures at CCH.
name is Lam Thich Chun. I'm on behalf of the City Children's Hospital and Infectious Disease Department. Today I would like to present for the COVID-19 prevention and screening procedure in Vietnam and at the City Children's Hospital also. As you know, that COVID-19 now is a global pandemic, and updated to May 23rd, there is over 5 million confirmed cases with more than 3,100 deaths. And updated to now is increased for 2 million confirmed cases and more than 100,000 deaths in only 2 weeks. The highest rate of COVID-19 infection occur among these countries: the United States, Brazil, Russia, Spain, and the UK. As you see, Vietnam has low infectious rate with only 325 confirmed cases with no mortality. And at the moment, we only have 334 cases without any death. Let me summarize about how the government responds to the COVID-19 outbreak in Vietnam. It was divided into 4 stages. The first solution occur from January 23rd to March 17th, and during this time we only have 16 cases in total. The government has well prepared before the outbreak, before the first case detection, and organized the National Steering Committee of Epidemic Prevention. Patients came from pandemic areas will have a medical check at entries and mandatory 14 days of quarantine. The second solution started when the 17th case is discovered on March 7th. The Health Declaration mobile application nCoV was legally allowed by Ministry of Health to ease the medical process and to disseminate accurate information quickly. And the social distancing is proactive applied. The policy now was quarantine the passengers who have symptoms and came from foreign countries. The third solution commenced when the detection of 2 new clusters with unclear origin in Hanoi and Ho Chi Minh. The policy at that time is the immigration suspensions, medical check, and mandatory 14 days quarantine for all passengers, and have a national lockdown for 14 days, including that closure of school, bars, restaurants, etc. And the last solution we have is when the community widespread and it moved to the next stage, and we have to protect the high-risk individual. Let me introduce the 4 levels of anti-COVID-19 isolation system in Vietnam. There are 4 levels. The first level applies for the confirmed cases and their close contacted family member. They will be kept at the medical facility for isolated and treated. The second level is applied for those who have close contact with a person with confirmed COVID-19 and their family member, and they will be sent to the to the quarantine centers. As you can see of the picture at the bottom, this is the quarantine center in Củ Chi district. The third level is called home quarantine, applied for those who exposed to people from the second level, and the fourth level is for the community quarantine. Now move to the CCH procedure to respond to the COVID-19 outbreak. We have the national guideline applied to all medical centers throughout the country, and the hospital procedure is based on the national guideline to make sure everyone can do it correctly. And we established the COVID-19 Prevention Committee and 2 responding force teams for COVID-19 treatment. We prepare sufficient equipment and medicine for maximum 100 COVID-19 patients. At CCH, the triage will be performed at entrance by administrative staff and are at clinic or at inpatient department by all the medical employees. And on anyone who comes to CCH, including staff, patients, and their parents, will be screened at the beginning. And they will be triaged for the health declaration, such as epidemiologic factors, cluster symptoms. They will check for the body temperature and respiratory symptoms. These are some pictures about the triage activity in our hospital. And each person who has passed the triage activity will receive the sticker to make sure that they have well health monitoring and they have checked for the temperature and respiratory symptoms, and they will follow the next step of the examination. It is a factor that we consider that they have to be isolated and have the laboratory tests for COVID-19. People who have close contact with, confirmed COVID-19 cases, or they have related or cluster symptoms of COVID-19, or they have a history of travel, especially from pandemic areas, or they have the pneumonia. They have a pneumonia with the chest X-ray images recommended to the COVID-19, or they have the ARDS or unknown causes. They will be considered for to isolated and have the laboratory tests. This is infectious disease department located separately with the purpose to isolation of the contagious disease. We have 6 isolation negative rooms for the COVID-19 with high technologies. We repair 99 ventilators. Yeah, 99 ventilators, the PPIs, medicines for the COVID-19 treatment process. We also use other facilities to support the isolation process, just that as you know that you see on the left side of a picture of the left, this is called the automatic sanitizer machine, and on the right side is called the cleaning robot. And on social media, we also use the such as video, hack radio, or the doctor application to our staff can provide updated information and remote healthcare service. City Children's Hospital laboratory can perform COVID-19 confirmed tests with capacity of 200 samples per day for quarantine centers and other regional hospitals. We in the last 3 months, we isolated 15 suspected case and 1 confirmed case with COVID-19. And this is the information about the positive case of COVID-19. And I will introduce Dr. Lai Hai Lộc. Lai Hai Lộc would like to present the confirmed case next to me. Thank you for listening.
Thank you very much, Dr. Jin. Next, please welcome Dr. Lau to deliver his speech on COVID-19 positive case reporting.
Sorry, Dr. Thank you, Dr. Jin, for inviting me. And it is an honor for me to be here today to present the positive case that we have chance to taken care of. So this is my report from me and my colleagues. So this is a Vietnamese 10-year-old boy traveling from Czech Republic, transferred to Istanbul airport for several hours and arrived to Trinity City on March the 15th, 2020 with his older brother. And both have isolated 13 days without any symptom, and his first RT-PCR SARS-CoV-2 negative. On the day 13 of quarantine, it's March 27, our patient got mild sneezing and have the second test positive. So he was transferred to CCH on March 31st. So after 14 days isolated with 3 negative RT-PCR SARS-CoV-2 tests, the boy discharged and had follow-up until May the 4th, when his nasal swab test confirmed reinfection. And he had been transferred back to CCH and again for another 14-day isolation. After 3 continuous negative results of nasal swab tests, he finally discharged on May 15 and kept following until now. Both admission durations, the patient was asymptomatic, and his family, including his parent and 1 older brother, had all routine tests negative. So this is a summary, a table to summarize the lab test results. So you can see from the table, he's only have 2 positive nasal swab tests. The first day on March 27, and the second time is on May the 4th, when he's confirmed reinfection. And the stool test also test positive on this day, like this one. And with blood test, we also test for the neutralizing antibodies, and we found the neutralizing antibodies on May the 6th. And besides, his first chest X-ray was performed on March 31st, show no lesion on both sides. During admission, this boy need no treatment. So all the features that we can summarize from this boy is that he's a 10-year-old boy, it's children case, and totally asymptomatic. And he has fast viral clearance from respiratory tract. And he also had what I call a reinfection, but I think it must be like prolonged infection, because we found the virus again in his respiratory tract on May the 4th. And no transmission to other person. His family and his older brother and even the older people staying in the same room with him in the isolation center also test negative. So because why we focus on this one? Because up until now, there's still a controversy raging over how a symptomatic case contributes to the transmission rate of SARS-CoV-2. We not yet understand the transmission procedure. And in the southern of Vietnam, based on 30 confirmed cases, from 25 to 58 years old of, at a quarantine center from March 10 to April 4th, we have a study that summarized since the national lockdown applied, we have 43% confirmed cases that has been discovered as asymptomatic. And in comparison to symptomatic confirmed case, those asymptomatic have lower probability of detecting virus in the nasal or throat swab test and have faster viral clearance from respiratory tract and also have high probability of transmission. So that's what I want to say today, because it's going to be good for our discussion. So, thank you.
Thank you very much, Dr. Lau. Now let's proceed with today's third section, Taiwan Smart Healthcare Solutions. Please welcome Ms. Xu to deliver her introduction on non-contact physiological sensing solutions.
Okay. Good afternoon, ladies and gentlemen. We are glad to be invited to join this webinar. And we are TPS from Taiwan, Taipei, and I'm Project Manager Yusia. Today, I'm going to introduce what solution we can provide. And before my introduction, here we have a short video about 1 minute to help you quickly understand what we do and our product features. Here we go. And all right, we have TK1000 and 2000 series in our product lines. And first you can see 1000 series provides a fast and convenient temperature monitoring solutions for epidemic situations. And we will provide a software like you can see on the right side to assist our users to monitor temperature screening. And when there is an abnormal situations, the system will automatically alarm and record by snapshots or videos. And that means you can check who is the object and when and where the object shows up. And we also provide a special function, which is people counting. And it could be applied to a variety of scenarios, like in an amusement park or a department store and so on. And the other features like we support temperature screening with people who wear masks and with glasses. And we also have face recognition function. And if people holding a cup of hot tea or a cup of hot water, the system will not trigger alarm. And here you may see our TK2000 series. And this series product especially provide non-contact physiological sensing solutions, which can simultaneously detect temperature, respiration, and heartbeat for now epidemic situations and the other healthcare application. And it has all the products features of 1000 series. And here you may see the comparison table, and you may see the model 48M is upgraded on thermal resolution. And the resolution is about 256 by 192 pixels. Our model 4K thermal resolution is 80 by 60 pixels, and which means the model 48M is detection distance, sensitivity, and accuracy get more higher, get more specific than model 4K. And it depends on the application that you may choose how to use. And 2000 series, as we mentioned before, besides temperature screening,
there are two more functions. One is heartbeat detections. The accuracy compared with ECG is about 90%. And the other function is respiration detections, and the accuracy is about 95%. And here you can see this is the solution for hospital use. And our device, you can see in a circle, is set up above the hospital bed to assist our medical staff to obtain the patient's physiological data in real time. And when the vital signs are abnormal, the physiological data could be thrown out to the system and the alarm will occur. And we hope this is the way to reduce the frequency of measuring physiological data in medical care and reduce the risk of infection. And in the future, the entire application system can be extended to rural areas to achieve remote medical treatment as well. So our products can be applied to mass transportation as well, like in the airport, train station, subway station, and bus station, and so on. And the other application, like in the school, hospital, community, and enterprise. And so far, we are working with the hospital in Taiwan for cooperation on how to import the patient's vital signs data to their system. And they plan to set up our product in the iodine 131 wards and isolation wards, using the monitoring and data management system of the nursing station and combined with the hospital's cloud system to reduce the frequency of medical personnel entering and leaving wards to avoid the impact of radiation or the risk of spreading infection. And we hope this is also the way to improve the quality of patient care and make really good use of the medical resources. And here is my sharing. Thank you for your time. I hope there is a chance to have a further discussion with you guys. Thank you.
Thank you, Ms. Xu. Now let's welcome Mr. Liu to deliver his speech on the monostereo 3D.
Hello. Hello, everyone. It's nice to meet you and attend this meeting. My name is Nick Liu. Our company is mainly focused on the medical image technology. So as you can see from my front page, you can see that Keep 2D See 3D. This word it's a little bit weird, I know, because why we keep 2D, but you still see the 3D, and then this is why we make the magic happen. Okay, so you can see this one is our product. It's just a simple little box here, but it can do the magic. Why we can make magic? It's because your hospital, you will have the 2D endoscope at your hospital for sure, right? But that they are all in 2D image. It means that when the surgeon or doctors doing the examination or surgery, the doctors can only see the flat information. They don't have the depth information. Okay, so if you have our little box here, monostereo, you can make the 2D image become 3D when you are doing the endoscope examination or surgery. So this is what we make, and also we by developing this technology, we win the Taiwan Excellence Prize, which is made by Taichua, and we already marketed it for many countries around the world since 2017. And how we make it become 3D, it's because that 2D endoscope, there is a light source, right? When you are doing the flexible endoscope or you are doing the rigid endoscope, there's a light source, always light source. Otherwise, you cannot see the things. Okay, so when you have a light source, you project to something that will reflect and create a depth map. So we use that depth map to give the image, the depth information, and make the 3D image for the doctors. When you do the diagnosis or when you do the surgery, you will have the depth information and make doctors to finish the surgery or to finish the diagnosis quickly. Okay, so what we solve is that you know that when you close one eye and when you try to touch the things, you will feel that it's very difficult. You know why? Because that you don't have the depth information, because you don't have two eyes. You only have one eye. So our magic is that we use the one eye's information and then create the two eyes information for the doctors. So we provide the depth of perception for the doctors. And so when you have our product, you can do the colonoscopy or gastroscopy or even a bronchoscopy in 3D. And also we have a very special function here. It's that we can reduce the dizziness from the doctors, because we have a special function that we can adjust different level of the depth information. So when you see the 3D movie, sometimes you wear the 3D glass, but you feel very tired after a long time watch. But now, if you wear the glasses, we use this function. You can set up different disparity. You can feel much better. Okay. So why we are unique? It's because we are only a box system. So you can connect with your current 2D endoscope. If you have the Olympus, if you have the Karl Storz, if you have the Pentax, you have something that you have, the endoscope you already have in your hospital. You just connect our system with that. And also we have a function that you can adjust different 3D level, and also the price is very competitive because you only need to add a box with a 3D monitor, and that you can have a 3D image. And also our technology allow you to have the 4K 3D image at once in the end of this year. Okay, so because we are making image system, so it allows to connect with many different brands of the endoscope. Okay, so it means that we can use that 3D for many specialties. For example, ENT, urology, general surgery, gynecology, or gastroenterology. So as long as the surgery or the examination needs the 2D endoscope, we can make it 3D. Okay. So this is something that is a very new sector here, because you have never heard that 3D bronchoscopy here around the world, because that is a very new concept. But we actually, by using our system, we can provide the depth information when the doctor is doing bronchoscopy. Okay, so that's very new, because I know a lot of doctors, especially for the chest doctors, when they placing the stem, they need the 3D information for it. And so I went to Taipei Veteran General Hospital a few weeks ago, and I would like to conduct a study with the hospital with Dr. Dares, and to find out the benefit of using the 3D bronchoscopy in the world, because this is the first system that can bring the 3D image for the chest doctors. So that could be interesting. Can you imagine that this image can become 3D and give the depth information? That would be very interesting. Okay, and also we have already sold many systems around the world to make the 3D colonoscopy and gastroscopy, and that would be very useful for the GI doctors to grab the polyps, and also when you do the ESD or ERCP, that makes you feel much easier. And this is the world first 3D system that can bring the 3D gastroscopy and colonoscopy to the doctors and for benefit for the patients. Okay, so we have been in Vietnam for 2 years now, and there's Vietnamese doctors. They are quite interested about this system, and also you can see the mayor of the Ho Nan City, Mr. Chong. He visited the center in Ho Nai and St. Paul Hospital, because they have already had our system in their operation room. And Dr. De Hua is a French doctor. He is working in the St. Paul Hospital. He is using our system for the nose surgery. Okay, so this is several news feed to talk about our system. Okay, and then if you are interested in this technology, we have already have our partner in Vietnam. Okay, so if you are interested, please feel free to contact us. Okay, thank you.
Thank you, Mr. Liu. Finally, we will conclude with the discussion section. We would like to hand things over to Dr. Hong to host this section. Dr. Hong, please.
I would like to invite Professor Yang to a kind of a chair this section. So that's yeah.
Okay. Thanks for the everyone. And it's great pleasure. We have a good opportunity to listen Taiwanese expert and Vietnamese expert to share the whole strategy and the evidence about COVID-19 prevention and the treatment. And additionally, we heard the two local companies to share the Taiwan Smart Healthcare Solution. So it's quite amazing. In this situation, Taiwan and Vietnam is successful overcome the COVID-19 infection. So we can join our experience and continue to cooperation to treatment and prevent further the other critical disease or infectious disease. So it's time to open to audience to ask any kind of question. I think that all speakers would like to share their answer to all of the questions from the audience. Any question from the Children's Hospital? I would like to ask first question to the Dr. Hong. Dr. you already shared about Taiwanese children cases. Would you expect that in the future, after the vaccination, the children will get a more effective protection from the vaccine, or adult will get a benefit from the vaccination? How about your opinion about the vaccination?
Thank you for Professor Yang's question. Actually, I reviewed the vaccination just early this month, and I think there are mRNA vaccine in the production line, and also some protein vaccine. I'm not sure whether the vaccine will work in the future, either in adults or in children. The reason for that is, first of all, there is a concern about the antibody-dependent enhancement of the vaccine. This is a situation when you get the infection once, you get a more severe disease on the second occasion, such as a dengue virus infection. There's a concern about that, but the vaccine development is still ongoing. We won't know until the vaccine has been introduced into human, and human beings have got a second chance to get the same infection. That's the first point. Another point is about all the vaccine development focuses on the S protein, the spike protein, on the surface of the virus. We are not sure whether the virus will continue to evolve and make new mutations. If new mutations appear, the vaccine might not work in the future. So maybe you can think it could be like a flu vaccine. You will need an annual injection to prevent from getting severe coronavirus infection.
Thanks, Dr. Hong, the expert opinion. So anyone, any question from the Vietnam? From the children? Yeah, please.
I have a question. You hear me?
Yeah, please.
Yes. I just have a question about the prolonged infection due to COVID in Taiwan. Do you have any experience, especially for testing for the neutralized testing antigen, or you can do other to confirm that the disease cannot there's no problem with the transmission if the patient have the prolonged infection. For example, in Vietnam until now we have 6 cases have recurrent or reinfection or prolonged infection after more than 20 days of negative. They have the positive in the swab test. And do you have any test special to detect the neutralized antibody to find out that there is no harm or no infection to other?
Yeah. Thank you for the question. Dr. Xiao, would like to answer the question?
Okay. Yeah, so the issue of reinfection is quite annoying, especially we have 3 negative results. And we do have a test for neutralizing antibody, for example, for our for our patient. but it is not widely available. It needs a special facility to test the neutralizing antibodies. And but I think the other issue of so-called reinfection is that we have to sure whether the virus is alive or is still have the ability to transmit it. So I think the ideal tool to check the so-called reinfection is that we have to have a good virus culture for the SARS-CoV-2. And that's why our CDC, as the Chief Hong says, our CDC check our patients who had a positive test after 3 negative results and show there's no ability for transmission. So it is probably due to the residual dead virus, and that is what we do for so-called reinfection. Yeah.
I would like to add more answer for this issue. Not just Taiwan, you can see the published paper from Korea. They surveyed hundreds of reinfection cases. There's no family or relative be infected by this kind of recurrent infection. So that means we don't know why the after 3 tries a negative randomized survey still get a positive. But this kind of positive reinfection actually cannot transmit, and they do virus culture still negative. So I think the item or definition for reinfection still need a big discussion. In Taiwan, if the patient have the 2 times negative PCR, would you consider they just cure and they don't need to isolate? So even they get another times positive result, we still just tell them keep wear mask and self-care. They don't need to be isolated, just as Dr. Hong mentioned about. The second question is about the rapid test. Right now in Taiwan, we just approved the rapid test for a neutralized antibody, but we did not approve the rapid test for the antigen. So we still need more research to do the antigen test in the future. But right now, we just rapid test for the antibody, I see. Okay, so any other question from the audience?
Yeah, thank you for your answer. Another question that about the policy. Do you have the what I call the field hospital to quarantine for the foreigner who come to Taiwan, and to follow up the evolution of these people to protect them from the infection, the COVID to the community?
You mean a quarantine policy?
Yes, quarantine policy. Yes.
Okay.
In community for the foreigner who come to Taiwan. For example, in Vietnam, you have the quarantine hospital field hospital to host for the people who come from the foreigner, for the overseas, and we can isolate them if they have something like suspected the symptom of the disease.
Yeah, we have a policy for the foreign or for overseas passenger. Dr. Hong, would I answer that?
Every foreigner, or even Taiwanese coming into this country, will need to go to the quarantine hotel and stay for 14 days. And they will continue self-health care. It's kind of home quarantine for another 7 days. That's our current policy. And they will all receive a kind of a follow-up a message on their phones or something like that. If they've got symptoms, our local health care authorities will send people to test them, or they will send them to the hospital for testing. That's our current policy.
And additionally, we use a high-tech tracing system. Every quarantine people need to register their cell phone, and we can control the movement of cell phone. So we can do the high-tech tracing, make sure they actually stay at home or stay in the hotel.
Yeah.
Okay.
like to ask Dr. Juan about the signs and symptoms of the children with COVID-19. You tell us about the multi-inflammatory syndrome in children. So is the some study in the UK and USA, they consider the MIS-C in children. Can you tell us your experience on that?
Thank you for your question. Actually, we don't really have any confirmed cases in the hospital, as all the cases might have all localized in hospitals close to the airport. So once the patients coming into the country, they are sent to the quarantine hotels, and if they got symptoms, they are sent to the nearby hospitals. And I think that's why we don't get any really confirmed cases. But I know the thing that you mentioned in the United States on their CDC website on the 29th of May, just about 3 weeks ago, they updated the guideline of a multi-system inflammatory syndrome in children. It's a syndrome like a cytokine storm. They ask all the physicians in the states to notify the CDC regarding this kind of presentation. And they've got the criteria, and I can't have all the criteria on top of my head at the moment. But we don't really have any severe cases in children in Taiwan at the moment. So I'm afraid I don't have more experience to share. And in some European countries, such as in Italy, they've observed more cases with Kawasaki-like illness. And it's a kind of 30 times more than what they observed over the past few years. So that's something that's rather interesting, that the virus can cause some kind of a immune dysregulation or something like that in kids.
Thank you.
Thank you. I want to have another question for Dr. Xiao.
Yep.
In your patient you present, is there the disorder of coagulation? Because we have in the adult patient, we found in severe condition, the patient developed the disorder of coagulation, especially the hypercoagulation. So that's why we have the one patient now is the pilot of the Vietnam Airlines. Now he on the hospital in 3 months, for 3 months. And we run the ECMO for them, and we found the ECMO clot with the blood clot. So the patient had the hypercoagulation. We had to change the ECMO system many times. Now he weaning from the ECMO and ventilator, but we also follow the some disorder of the coagulation. So can you tell us about your patient on the coagulation situation?
Yeah, thank you for the question. Excellent question. Indeed, there's the issue talking about the hypercoagulation status of the COVID-19. And actually, initially, when the patient arrived in our hospital, we can accept the very severe hypoxemia. We can see also an elevated D dimer, and indicated that there is something wrong with its coagulation status. And our patient was on the ECMO, so I think it is mandatory to use some anticoagulant to keep the VV ECMO moving. But the prolonged use of the VV ECMO forced us to withhold the anticoagulant and remove that after about 40 days. And we do have experience from other hospital to use anticoagulant in this severe COVID-19 patient. But in our case, in our hospital, because except the severe cases with the ECMO, which is mandatory to use anticoagulant. We don't have other cases such as milder disease to use anticoagulant to treat the COVID-19. Yeah.
I think it's a big issue for treatment of severe COVID-19 cases. Like our case used to prolong the ECMO, so actually face a very high risk of hypercoagulant. I think this issue may cause the ECMO failure, but we need to carefully monitor the coagulation factor and try to balance the coagulation and the thrombolytic, and just keep close monitor. Then we will save the case. That's our answer. Thank you. So any question from the audience?
In your patient, I found that Dr. Xiao, you use the anti-delay gene is for what the candidate infection or other fungi. What purpose you use the anti-delay gene?
Yeah, yes, we do use the antifungal agent for this patient, but that is based on the culture of her trachea aspirate, which yield candida in maybe in the day 10 maybe, and according to this culture result and the elevated sepsis profile, so that's why we gave the antifungus agent for this patient. That is based on the culture result. Yeah.
Yeah, we had the problem about the nosocomial infection, so that we would like to ask you about how to prevent and how to treat the patient with the nosocomial infection, especially some antibiotics such as the tetracycline is what's the organism do you treat for?
Yes, thank you for your question. I think the nosocomial infection is absolutely crucial for those patients with COVID-19, especially severe COVID-19 patients. And therefore, our clinical guidelines published by our Taiwan Society of Pulmonary Critical Care Medicine and our CDC all recommend that to remember to use empirical antibiotics according to the local data and the current guideline. For example, we have a Taiwanese guideline for pneumonia, and that really gave us some reference to see if there's a co-infection with something like bacterial infection, especially severe ARDS and severe infection. You should cover Pseudomonas infection with beta-lactam and maybe another non-beta-lactam medication, and also add on anti-MRSA medication for recently infection. So I think we have a good guideline to follow. That is why we face the nosocomial infection. Yeah, but on the other hand, I think there are also some protocols to reduce the, for example, the ventilator-associated pneumonia. For example, the positioning of the patient's head and gently feeding the patients with the NG pump, and also our hygiene every day by our nurse. That is what we done for reducing the nosocomial infection. Yep.
Thank you. And one final question is about, I'm very impressive your result of the ultrasound on lung of patient compared to the CT scan, lung CT scan in patient. How you perform the CT scan for the patient? You move the patient to the CT scan room, or you have the ambulatory CT scan?
Yeah, unfortunately, we don't have an ambulatory CT scan. And the CT scan showing on my slide, it is after the intubation of the endotracheal tube, and the patient was relatively stable with a very low oxygen supply. And I think that is why I focus on the role of lung ultrasound to give us a real time and non-invasive way to monitor disease status instead of the CT scan, because I think I think you can agree that in a patient with a critical ill COVID-19 and ARDS and even shock status, it is very dangerous and unsafe to transfer out the patient to ICU, and it may increase the risk of SARS-CoV-2 spreading. So actually, we don't have a CT scan for our patients from our hospital, despite of their severity initially. And we only do the CT scan after the patient's recovery and or some like negative test for 3-THAT and free from isolation. We will do the chest CT. But during admission, we don't have any CT result. Yeah, so that's why we encourage our physician to use the lung ultrasound to monitor disease status. Yes.
We think the bedside ultrasound is a more convenient way to monitor the patient lung condition. We all know that transfer patient to the CT room, we will take the high risk for the virus transmission or patient conditions worsening. So I think a skill for the ultrasound technique will be very helpful to monitor and to see the response of patient care. That's our result. So thank you.
The doctor, the intensivist perform the ultrasound, or the doctor experts on the ultrasound do the ecology.
Yeah, the ultrasound was done by me. I'm an intensivist. Yeah, not by our radiologist, but by me. I'm a pulmonologist and intensivist, and that is our standard training program from our fellowship. Yeah, so I'm quite familiar with the lung ultrasound since I was a fellow. Yeah, so that is not a typical things for me actually. Yes. And all pulmonologists in Taiwan, I believe, are very skillful on the lung ultrasound. Yeah.
Thank you.
Okay, thank you. So any
one question from our radiologist. She want to ask a question.
Sure, please.
Good evening. I'm Dr. Khan. I'm from the Diagnostic Imaging Department of the CCH Hospital. I want to ask about the question according to the imaging of the patient of COVID-19. I want to ask, according to your reference, how often do we need to re-evaluate the patient's lung using the ultrasound or the CT? I think that we have to concern that the fact that each time we do the ultrasound or do the CT, we have to close contact between the patient and the medical worker. So I think that we just do the ultrasound or the CT when the patient is really need. And so my question is, how often do we need to re-evaluate the patient's lung using the ultrasound?
Yeah, I think that is a good question. How frequent we should do the lung ultrasound for our severe patient with COVID-19? I would say that will based on the patient's condition, actually. For example, when the patient was in ARDS status, I actually done the lung ultrasound every day, even twice a day. For example, before the recruitment maneuver and after the recruitment maneuver. And the purpose of why I do that is that I want to monitor the effect of our treatment. And the result from our slide showing that it is really encourage us to believe that the patient's lung is still recruitable based on the lung ultrasound finding, instead of the chest X-ray, which showed no no significant change. And after the patient decannulated from the ECMO and weaning from the ventilator, and patient got improved, I think it is no need to do the lung ultrasound every day. So during the rehabilitation status on the last 2 or 3 weeks of her admission, I usually do the lung ultrasound every week. Yeah, so I think you're excellent question, but I think the lung ultrasound, how frequent do we do the lung ultrasound is actually based on the patient's condition. And I think that is the most beautiful things of lung ultrasound, because it is non-invasive and it can provide you real-time information. So you can do that anytime as you want. Yes.
Yeah. Actually, we keep the one ultrasound in our negative pressure isolation room. So if the intensivist they want to check that, they can do it at any time. So I think we don't have a very rigid regular interval to do ultrasound. But if a patient need, if a doctor sees considerable, they just do it. Yeah.
Thank you.
So any other question from the Children's Hospital? Oh, yeah. Any question? No more question. So I think it is a good chance we can share the COVID-19 prevention and the treatment policy between Taiwan and the Vietnam Children's Hospital. So it is a good way to share our experience. I hope in the future we can handle another similar webinar, and we can exchange our more experience between us. So it is my pleasure to close the section, and thanks to every speaker. Yeah, she was a very good report and presentation. Thanks for all. And then any other want to speak something? Children's Hospital, anyone want to say something for this section?
Yeah. We on behalf of our hospital and director board, we would like to thank all of you with the research lecturer and topic, and we learned a lot from you, and we hope that in the future we have more sessions like that to training our staff and the junior doctor to understand and get more knowledge and skill, and especially the research experience from you. And we hope our hospital will cooperate and collaborate with you in the future with more development, and we hope to meet you offline on the meeting in the future. Thank you so much.
Yeah, thank you. We hope we can cooperate in the future between Taiwan and Vietnam. Thanks for everyone joining this meeting. Thank you.
Thank you very much. Ladies and gentlemen, thank you for being here and making this event a pleasant experience for all of us. We hope you have enjoyed today's program. And also our Director of Taiwan Trade Center Representative Office in Ho Chi Minh City, Mr. Kevin Zhang, is also online today. If you have any further questions or ideas to follow up, please feel free to contact with Director Zhang. Thank you again and have a nice evening.